Hey, welcome to the GoTo Physio podcast. In today's show, I talk about the presentation I gave at Therapy Expo called The Role of the Diaphragm and Pelvic Floor on Most Musculoskeletal Conditions. I hope you enjoy the show. Hey, welcome to the GoTo Physio podcast. And today's show, we're going to go back to higher level thinking and take a break from hearing from how other therapists are implementing this content in the real world. So I've just got back from Birmingham. We had a brilliant 2 days down in the Therapy Expo. I really like that event. I think it's a great event. I think it brings together physios, sports therapists, chiropractors, osteopaths. I got to chat to quite a range of therapists, strength and conditioning coaches, and then obviously it's good to see all the exhibits, and you get a really nice variety of different speakers. So what I want to do today is talk about the presentation that I went and delivered on the first day. We were very fortunate to have the lecture theatre full. There was standing room only, and then they actually stopped people coming in. So really humbled by the response and by the feedback of therapists throughout the 2 days. So what I'm going to do now is I'm just going to run through an outline of the presentation. Obviously, it's not going to be the same as being in the actual theatre, because there was quite a lot of videos and research papers that I went through in the presentation, but hopefully it'll give you an understanding. So what we talked about and an overview of the presentation, we talked, and we will talk now in the coming minutes, about stress and pain contributors and really the importance of pelvic floor and diaphragm range of motion to peripheral joint tissues. And then the big thing was practical applications in the real world. Now, you might remember episode 8, I talked a lot about the importance of ribcage mobility and diaphragm range of motion. So again, this episode here would build on from that. So again, I showed a video in one of the first slides, and it was how the diaphragm, and I'm just going to play the video as I talk through it, as the diaphragm lengthens, it helps expel the lower lungs, okay, the air from the lower lungs. So a nice visual of the diaphragm as it shortens, the lungs expand. As the diaphragm lengthens, the lower lungs essentially ascend, okay. So there's a really nice image there of that kind of parallel movement of the diaphragm and the lower lungs. So as we breathe in, the diaphragm contracts and flattens. As we exhale, the diaphragm stretches, and so does the lower lungs go upwards. Okay, so that almost goes into a dome shape as well to expel that lower lung air, and we know that's very, very rich and important to be able to utilize. So that was one of the things. Then I showed in the video that actually, you know what, in between the diaphragm and pelvic floor is a lot of vital organs. So a lot of people with IBS and various other issues, and you know, we talk about visceral manipulation, that's becoming more popular these days. Well, actually, tell you what, why don't we just get the diaphragm and pelvic floor moving? All of these tissues will get moving, and then we can mobilize all these tissues and fascia. And then the next image was of the nervous system, and then the big thing is the rib cage obviously sits over the lungs and the diaphragm as well. So that has to mobilize as the rib cage and the diaphragm mobilizes. The next slide was, and again I've got it in front of me here, as we breathe in, the diaphragm is going to come down, the TVA is going to stretch, the rectus abdominis, the obliques are going to lengthen also. The rib cage is going to expand in 360, and as we exhale and the diaphragm stretches, the TVA is going to contract, and along with the rectus abdominis and the obliques. The next slide I showed full range of motion on a daily basis and how people may work around an inability to lengthen the diaphragm. So one of the biggest things is when you go to touch your toes, people won't want to flex through the upper thoracic. That's a big sign. They'll almost initiate the movement with a straight back as they go to touch their toes. And what they do is they almost reach out in front of them. So again, my toes are down underneath my eyes essentially, but a lot of people, when they go to touch toes, they reach out first. So again, they're moving around these limitations. When you go to touch your toes, give or take, okay, again, not 100% accurate, but just so you can understand this, we want the upper thoracic, the mid, the lower, the abdominals to all do 25% each. We don't want the lower back to be working concentrically while you're trying to touch your toes. Okay, it just doesn't make sense as a as a movement strategy, to me, why your low back would work concentrically to try touch your toes. Okay, the neck is going to be a big indicator as well. Okay, and again, I'm not talking about heavy lifting or anything like that, or deadlifting or anything like that. But when you want to touch your toes, that's the outcome, that's the task. We want to go straight down to the toes. Okay, you want to get from point A to point B. Why are you going point A to point B via point C? Okay, so a lot of people are reaching outwards to touch the toes. Importance of the diaphragms and the pelvic floor's full range of motion on a daily basis. Then I showed a picture of a female putting on her socks. Okay, so when you go to put your socks on in the morning, which a lot of people struggle with, I was actually in the gym this morning with a guy, and he said to me, "Oh, my back went when I was putting on my socks." Okay, again, he's actually deadlifting. He's probably half the weight of me, and he's actually deadlifting about 20 kg more than me at the moment. So he's been doing a lot of deadlifting. Again, when he was talking like that, I was thinking his iliocostalis had probably some protective tone. When he goes to put his socks on, that's, you know, the straw that broke the camel's back, so to speak. It wasn't putting his socks on, it was the inability of these tissues to go through a full range of motion. Rib cage needs to depress, diaphragm lengthens, iliocostalis lengthens. Iliocostalis goes from the rib cage right down to the thoracic lumbar fascia. So he's feeling all in his thoracic lumbar fascia. My advice was, look, let's get your mid back, your rib cage moving, and see how you feel. Okay, so when you go to put your socks on, if you sit on the edge of the chair now, and you go down as if you're about to tie your shoelace, you need a lot of range of motion through that diaphragm. You need a lot of depression. So then the next slide was stress precedes pain. So again, we can see now that the research is not just about previous injury, but it's actually about, you know, if you've had an injury on that limb, you may be more likely to pick up an injury. That was a systematic review paper by Liam Toohey and colleagues. Caroline Finch, again, she's a really good researcher. Jill Cook was involved in that paper as well. Then I talked a little bit about what we already know about previous injuries and about moving away from painful or stressful areas. And then also a big thing that we know about, predicting injury is a lack of sleep. So again, a lack of sleep, that to me is an inefficient, poor sleep, I should say, is inefficient breathing mechanics, okay? Because again, the breathing mechanics are going to have a big impact on our ability to get into rest and digest, okay? So again, the exhalation is going to be very important to help us get into rest and digest, because essentially exhalation is rest and digest, inhalation is more sympathetic, okay, or fight or flight. So again, we want to make sure that we can fully lengthen the diaphragm, we can fully exhale, we can spend more time in exhalation than inhalation, we can spend more time in rest and digest. So next slide, I looked at the role of chronic emotional stress and increased mental load, where we alter our respiratory regulation in several ways. We increase the respiratory drive, we alter our breathing pattern and timing, which is essentially going to react to our respiratory drive. So we increase our breathing rate, basically. So you think someone who's stressed, or in extreme case hyperventilation, and then we get this altered breathing pattern and timing to adjust to that, okay? And then we get a metabolical appropriateness of the respiratory response mismatch, okay? So how you're breathing, your metabolical or your respiratory response to actually what's happening in your body is inappropriate. So your breathing pattern, timing, your respiratory drive is essentially the same as if you should be running a marathon, okay, or you should be sprinting, okay? Probably not sprinting, but you get my point. Whereas you're just sat at a desk and your respiratory drive, your breathing pattern, your timing, your breathing, it's as if you need a lot more air into the lungs. Whereas actually the reality is you're sat at a desk, you're doing work, but your boss is coming and it's stressing you. There's something going on in your home life maybe, and your breathing pattern is a result of altered respiratory drive, okay? So again, non-physical stress is very important. Hey, I hope you're enjoying today's show. For more clinical content and tips to help you implement this content in the real world, please visit GoToPhysio.com for more information, including my 6-step patient adherence checklist, which you can download for free. And also there's more blog content that helps you implement this stuff in the real world. You'll also find links to my YouTube show, the GoTo Physio show, as well as lots of more information to help you become the go-to therapist, helping real patients get real results in the real world. The next slide, again, I'm not going to go through everything, but one of the big things was your respiratory drive is going to be altered in anticipation of coming physical and emotional events. Okay, we've had a few little issues here in the clinic, a lot of stress, going on with bits and pieces, and I could feel my chest, my breathing rate change quite a bit. Okay, so again, the reality is, in that present moment, I was absolutely safe. There was nothing happening, but I'm thinking about what could happen or what might happen. Okay, again, that perceived threat of what might happen. So that should sound very familiar from a physical point of view as well. Okay, so the anticipation of coming events has a distinct effect on increasing respiratory rate, reducing time of exhalation, and changing the respiratory pattern. So the exhalation is the key here, because we want to fully lengthen the diaphragm. Okay, now it's not all about exhalation, don't get me wrong, but it's a very, very important part of it. Okay, I had a patient the other day, and I used the analogy with her, and she was really struggling to lengthen her diaphragm, and it was almost like a case of when she exhaled, she felt like she was panicking, like she couldn't breathe, like she had to really inhale really quickly. So what I said to her was, it's almost like, you go to touch your toes for the first time in a long time, your hamstrings are screaming at you, they feel so tight. Okay, and that's a similar sensation. What that sensation's giving you as you go to touch your toes, your hamstrings are like, hey, I don't like stretching these, come out of this position. Okay, it's the same as you exhale, your brain and your chemoreceptors saying, whoa, I haven't been in this position a long time, I need to shorten again. And that's where you not naturally get that gasp in. Okay, so the reducing exhalations is pretty important. So again, the next slide, one of the key points on it was we were responding to our emotions. Okay, our breathing rate's responding to our emotions rather than metabolic cues from chemoreceptors. So the chemoreceptors may not be aligned with the actual physical needs of the body or its metabolic requirements, but may be reacting rather to our emotions. Okay, again, a lot of people are emotional these days. There's a lot more awareness around mental health, etc. And that's a story for another day. But again, a lot of this stuff can help a lot of that. When mental and emotional factors such as fear, grief, anxiety, or depression drive our breathing regulation, homeostatic and biomechanical inappropriate breathing tune to the anticipation of action that does not occur. Okay, so again, if you think of your persistent back pain patients, how many of these factors are at play? Fear, grief, anxiety, depression. Okay, so again, it's that fear of movement. Every time we're going to move, we hold our breath, we take a breath in, we lose the ability to exhale. Okay, so then the next slide was an altered image from Louis Gifford's mature organism model, showing that all the similar input from the environment, from tissues, etc., that's gone up to the higher centers. The higher center scrutinizes it. We get this output, which is altered behavior, altered physiology. Okay, so again, our physiology being our breathing rate there. Okay, so then I showed the video again, the inability of the diaphragm to lengthen. We get this shortened contraction. Again, you take some real shallow, almost hyperventilations, and you'll feel how your diaphragm can't lengthen. Okay, so rapid shallow thoracic dominant breathing, high levels of tonic contraction of respiratory muscles is found in situations requiring high levels of ventilation, probably indicates the system is having difficulty returning to a state of rest. Energy is wasted and homeostatic functions are needed for renewal and repair are impaired. Okay, so again, we know that when we sleep, we recover. Ideally, we want to be in rest and digest to recover. If we're in our sympathetic nervous system, cortisol's kicking in, we're not repairing, replenishing, we're using energy. So energy is wasted. So that's where, when we do a lot of this stuff with patients, one of the biggest things they'll say, oh, I haven't slept that well in years. Okay, so again, they're refreshed because they're actually in rest and digest, and they feel like they have more energy, their mind is quietened, and they said, you've a busy mind, that is absolutely exhausting. You quieten your mind down, you use breathing, meditation, mindfulness, whatever you're using, that's a very, very different feeling. Again, that's variability within your thoughts, isn't it? So again, for a lot of people with a lack of variability, they've got all of this stuff going on, a very, very busy mind. It can be exhausting. Then I used a slide labeled Beliefs and Pain Science Application, and I used the formula thought, emotion, behavioral reaction. So usually the cycle is we have a thought, we have an emotion. Because of the thought, we have a behavioral reaction because of the emotion. Eddie Jones said a really good phrase in Japan. I think it was the All Blacks week. He said, how you think is how you feel is how you behave. Okay, and again, one of the docs that I know, he said, oh, is that cognitive behavioral therapy 101? Absolutely, you know. So again, we want to change how you think, how you feel, how you behave. Or what we can do is when your thought comes into your mind, instead of having a negative emotion, we can use that as a trigger to get you into the present moment, restore your breath. When you focus on your breath, you're in the present moment. Okay, so again, we stop that emotion and our thoughts running away at themselves of what might happen with these negative emotions and altered behavior. So we have a negative thought, we stop it in its tracks, we don't allow the emotion to come through that causes a behavioral reaction of the respiratory system. Fluoroscopic studies have shown in situations of emotional stress, the diaphragm shows signs of hypertonicity becoming flattened and immobile. So again, we want to restore the ability to lengthen. Okay, then I showed an example of real world stress. A guy, one of the brothers, the triathlon brothers, Brownlee, I think it is, I can't think of his name, I think it's Brownlee, I might be saying that wrong. When he was going to the finish line and I think his brother carried him, there's a little moment in that clip where he's on his own and he's just about to fall into a guy and you see a little dink of his rib cage where he goes into extension. Again, that in my opinion is his diaphragm absolutely contracting. Then we talked a lot about different studies and how to see this stuff in the real world. And one of the studies, Pavel Kolar study, postural function of diaphragm in persons with and without chronic low back pain, showed a visual there that, again, with people with chronic low back pain, we see that there's a less range of motion through the diaphragm, and the diaphragm is actually situated a little bit higher. Okay, so when the rib cage elevates, that diaphragm is going to appear to be risen or appear to a little bit higher. Okay, all things being equal. But the big thing here that I wanted to show from that study is we lose range of motion. Then I showed a couple of examples in the clinic in the real world, rethinking our assessments. Then I showed of actually that the rib cage and the pelvis are going to react to each other, and that sometimes it's not all about the hip or the glute med, that actually the rib cage can be driving a lot of that. We talk a lot about that obviously in the mentorship and the return to play courses as well. The importance of a normal breathing pattern for an effective abdominal hollowing maneuver. Okay, so that was one study. Again, when we contract these tissues in sync with our respiratory system, lo and behold, we get a much stronger contraction of the TVA. Then we looked at the effects of diaphragm stretching on posterior train, muscle kinematics, rib cage, abdominal excursion, a randomized control trial, and showed the reactions peripheral tissues have to the rib cage. So again, when the rib cage elevates, the pelvis is usually going to anterior tilt. That's going to change length-tension relationships of hamstrings, abdominals, etc. So the key thing here, when we lengthen the diaphragm, we can help a posterior tilt, we can take tension off some of those hamstring tightness. So if you've ever had a player, GA player, rugby player with tight hamstrings, tight calves, low back, my approach would be, let's get some length through the rib cage, diaphragm, let's mobilize the rib cage and get that person back into rest and digest, and lo and behold, 9 times out of 10 the hamstrings will desensitize very quickly. You may need to a little bit on the hammies, but very often that would be the thing. Now, what I warned in Birmingham was actually don't get too obsessed or fall in love with these quick changes. Okay, anyone can stretch your hamstrings quickly, and then when you retest, all of a sudden you can touch your toes. What I'm interested in is go for a walk for 5 minutes, live your life, come back, retest your toe touch. Has it stuck? Okay, and that's where the graded exposure program, which I talked about in the second talk of my main talks in Birmingham, that's why the graded exposure is so important. Okay, so we looked at physiological properties of muscle tendons, altered length tension relationships, muscles have optimal lengths, optimal rate of length change. Showed a couple of studies of why the torso is very important and how that reacts to the peripheral tissues, the importance of the trunk posture on lower extremity energetics, and then we started to look at the upper rib cage also. Okay, then we started to focus on mouth breathing, the importance to get you nasal breathing, again to slow down the pressures, to give the lungs the best chance of inflating. We looked at the effects of dome and of the diaphragm in subjects with short hamstring syndrome. We talked a lot about that. Then we started looking at the pelvic floor, the movements, the importance of the pelvic floor to posterior tilts. And then we looked at tongue postures. Again, nice study, mood-induced variations of mandible and tongue postures. When they watch scary movies, the jaw tended to drop. Okay, so again, we lost tongue position. We're going towards fight or flight. Okay, then we looked at postural stability, affected tongue position, and also the acute effects of tongue position in the mouth on knee as a kinetic test performance. So again, there's a lot to be said for correct tongue position. We showed some practical applications. Again, hip flexion, get the rib cage depressed, recheck hip flexion and internal rotation, and you might be surprised. Then we looked at practically applying this, restore variability centrally and peripherally, show the brain it's safe to tolerate loads in all directions, update the belief system both consciously, subconsciously through education, movement, and hands-on facilitation if necessary. Then I looked at the importance of getting load through the peripheral tissues to undo some of these physical stressors, and the importance of the rib cage to depress, lower back to relax, diaphragm lengthening, how that can have a massive impact on the ability to put load in certain tissues. Then last slide, practical demo, just giving a plug that actually I was going to do an assessment and treatment of diaphragm, pelvic floor and lower back pain patients, which again was very well attended that day. And then the final slide was a little slide just to say that I'm doing an online return to play course the 13th and 20th of December. I think it's at 10 o'clock to 1 o'clock UK time, which is to fit in with the evening time in Australia and New Zealand. And that's all about getting structured confidence and knowing or how to progress or regress any patient using the exact step-by-step system progressions I used in the Rugby Union World Cup. So there's still time. That course starts for the week. This at the time of recording this, Friday coming, I'm in Ireland for the Irish Return to Play course, final one of the year. And the following two Fridays, I'm going to be doing 2-3 hours online return to play. We've got state-of-the-art camera equipment, so it'll be literally like you're in the room with us, and you'll have access to those presentations and the recordings for a few weeks after, so you can actually consume the content. So that was it. Very, very quickly taking you through the presentation. I appreciate when you're not in the room, you can't see the videos or the slides, a little bit harder to get value from, but I am planning on maybe potentially doing this as maybe a webinar at some point. But if you want to, stop messing around, you want to get stuck into it, you want to understand this stuff inside out, then log on to www.thegotophysio.com/mentorship. I've got whole modules on this, and I'll show you exactly how I assess, how I treat, how we give a graded exposure to get long-lasting results. So you're not Mickey mousing around with this stuff and getting short-term changes. If you want to know how to do it, how to get a graded exposure, then have a look at the mentorship. Reach out to us, and if you want to have a chat, then come on. And I'm more than happy to show you around the members area, complete transparency, what it is, what it isn't. And as I said, I think this stuff's very important. It can help a lot of your patients, even lower limb issues like shin splints, all of this stuff. I think it's involved in a lot of this stuff. I'll show you to assess it, how to desensitize, how to give that graded exposure. It's not that complicated, as well as many other stuff. Okay, so that's it for today. I hope you enjoyed this episode. As I said, www.thegotophysio.com. There's loads of resources there. You can pick up the book, the Return to Play course, mentorship, the GoTo Physio show, loads and loads of stuff there to help you become that go-to therapist in the real world. Most importantly, make sense of real world symptoms and presentations to take action and get long-lasting, meaningful results for your patients. So it's not just about sounding smart on the internet, but it's actually about, seeing what you're seeing or what you're looking at in front of you, taking action and helping people get long-lasting results. That's what we're all about here. And as I said, we've got a new class coming up starting in January. We'd love to have you on board if you're open-minded, if you're hungry, if you want to give your patients the best level of care, but most importantly, you want to make long-lasting impacts on their lives. Hey, I hope you enjoyed today's show. For more information, please visit www.thegotophysio.com, where you can download my 6-step patient adherence checklist absolutely free, as well as read the accompanying blog that goes with today's episode. We've got lots of cheat sheets and clinical content to help you implement to get real world results with real patients that ultimately helps you become the go-to therapist and allows you to build a profitable, busy private practice or become that go-to therapist in professional sport. I'll speak to you soon on the next episode.